like
I use this dots and ellipses.
I was
to drive
saw that.
25
Oh, it was like, no. Yeah, that's.
That I was like, if anything, I'll give you that's funny.
We're all good.
I'm applying for.
Oh, it's fine. She said
Go
yes.
to-
Wait. When?
I mean.
2025.
Yeah.
All right, great to see everybody. It is such a pleasure to introduce Molly Rosenberg. Many of you already know her. She finished her PhD here at UNC in epidemiology in 2014. And went on to do a postdoc at Harvard, working a lot with Lisa Berkman and continuing to work in South Africa, where she worked during her dissertation with Audrey and others. And she has a longstanding interest in how poverty alleviation programs can influence health, and amazing experience in a couple of different randomized controlled trials, and has also done work continuously in Haiti, which is the place that she was in the Peace Corps. I'm impressed and intrigued by all the different things you've done, and it's great to have you here. And today, Molly will be talking about cash transfers to promote healthy aging in low-income settings with evidence from rural South Africa.
Thank you so much, Elizabeth, for the kind introduction. I'm gonna let Hillary Hecht in. Is that okay? Okay. So thanks for the invitation to come back to the CPC to give this talk, and for all the organization that went into it. It feels like coming home a little bit. This was a place that I spent a lot of time, not in this physical building, but in the general like CPC good vibes space. And I am really excited to be sharing this work from South Africa with this group of population scientists. Here our team is looking at how cash transfers could help promote healthy aging in like a low income setting. I find that population science and global health work in general requires a team science approach, and this project is no different. So I'd like to acknowledge the partnerships with here at UNC with Audrey, but also at the University of Michigan, at the Harvard Pop Center, where I did my postdoc, and the University of the Witwatersrand in Johannesburg. And I'll get a little bit more specific about those as I go. Great. And here's what I'd like to cover today. I'll start with some background on the dynamics of population aging and low income settings generally, and in sub-Saharan Africa in particular. And we'll talk through why we think cash transfers might be useful to address aging related outcomes and address equity and health concerns more broadly. Then I'll present some work from a series of studies we have going on in this area. I'll do a deep dive into a relatively new analysis we have looking at the effects of a randomized control trial of a cash transfer on memory decline, which I think is useful for setting the stage for some other findings that we have and understanding the data structures that we're working with. And then I'll cycle through a little more quickly through a series of other analyses looking at different cash transfer schemes and different aging related outcomes. So we can hopefully end up at a summary conclusion and triangulation across that body of work. And then I'm going to set up the rationale for this project by first pointing out the really stark differences in life expectancy in low and middle income countries versus high income countries. Lower income countries, in particular sub-Saharan Africa, which you can see in the like lighter colors here, have life expectancies that have barely cracked into the 60s, while higher income countries have populations that live lives that are predicted to be more than a decade longer than that. At the same time, lower income countries in sub-Saharan African settings are the places where aging populations are rapidly growing, in part because we have this like higher ceiling there. Populations of Africans over the age of 65 in particular are expected to more than triple by 2050. So a big aging boom in these areas that have lower life expectancies now. And with that aging population structure, dementia cases are predicted to be on the rise, and a shifting burden of those dementia cases from high income country settings to lower income country settings, with 75% of cases of dementia expected to be in lower income country settings by 2050. So low life expectancy now, projected to rapidly increase over the coming decades, and like with that, a dementia boom coming. So there's this urgent need to address this. Like, what are things that we can do? We're anticipating this to happen, and it's like currently happening. What can we do to promote healthy longevity and promote cognitive health in these lower income country settings? And we think that cash transfers are one intervention that could plausibly help here. Cash transfers are interventions that provide income to recipients through direct cash payments. We know across like a really pretty consistent body of literature that low income and low socioeconomic status are related to things like mortality and cognitive function. And that has been consistent across time and space. And we also have a pretty strong evidence base specific to dementia and cognitive function that it's really pretty heavily socially patterned, where socioeconomic exposures across the life course accumulate and end up in higher risk for dementia and increased cognitive decline. So we like have this, we don't necessarily have interventions specified to address this knowledge base yet. And most of the data around this is coming from high income country settings. All right. So we were thinking cash transfers are a useful intervention to sort of move from this evidence base of knowledge that low socioeconomic status is associated with these aging related health outcomes, but like maybe we can intervene on it in this way. But reasons that we like, practical reasons why we think this might be working is through the accumulation that income gives us of like access to better healthcare and healthcare utilization. You can buy things with that money that might be cognitively stimulating in some ways. You can buy healthy food, access to water, make investments in your household infrastructure that could, you know, like lead directly to improved health across the life course, but also reduce stress associated with living in a lower income setting. So basically, like, money is good. We think money is good in general, and that we'll also be able to see the effects of it in these longer term aging related outcomes. What else did I want to say here? Oh, and then this project also works within this framework of cognitive reserve theory. This is a theoretical construct that says some adults can withstand brain pathophysiology, like changes to their brains that would normally be associated with dementia, but they're still cognitively performing well. And basically because they've built up some sort of reserve that allows them to withstand that over time. And a lot of cognitive reserve theorists think that you build cognitive reserve through lifetime accumulation of cognitively stimulating activities. So things like education, things like a good diet, things like low stress across your life course could plausibly build this reserve of ability to be able to withstand the normal wear and tear of aging better. So we think income injections from cash transfers could help with this in this space and like within this theoretical construct. All right. But the evidence base is pretty sparse here, specifically with cash transfers and aging related outcomes, in part, I think, because randomized cash transfer experiments are rare. And in the real world, cash transfers are often targeted to specific groups of people. And so issues of endogeneity are there when you're trying to evaluate it for health outcomes. But then specifically with health related outcomes, really be like long-term longitudinal follow-up to be able to see the impacts of like a cash transfer exposure that maybe happened a long time ago to a population that has aged enough to see the effects of it. And when we're thinking about cash transfer evaluation timeframes, they're often looking at much shorter term impacts because of practical reasons with funding and things like that. You don't often get cohorts of people aging into the aging related outcomes that we're interested in the ADRD space. And then finally, there is a growing body of evidence pointing us to the fact that cash transfers can often work differently for different kinds of people. So it's important to formally incorporate stratified analyses and subgroup analyses, for example, by sex and age and education and a baseline socioeconomic status, to be able to see like who are the people who would most benefit from these kinds of interventions, or who are the people who are not benefiting from it, and how could we sort of tailor cash transfer interventions in the future towards them. So with that set up, I'm going to head into some more details on what I think is an exciting new analysis we've been working on to estimate the actual causal effects of cash transfers on memory decline. To do this, we were able to address quite a few of the gaps in the literature. We had access to an actual randomized cash transfer experiment, thanks to Audrey Pettifor, that was administered in a rural South African community with linkage to an older adult cohort that had those rigorous longitudinal aging-related outcomes measured. And the study setting is from rural Mpumalanga province in South Africa in the northeast corner of the country. This is where the Agincourt Health and Sociodemographic Surveillance Site has run a census-based research platform since the early 1990s. They have a truly expansive research portfolio and capacity, but for the purposes of this study, I wanted to highlight that they collect complete data on vital events for every single person living in every single study village under observation in their surveillance site. They currently represent more than 117,000 people. So this is like a huge and rich data set. And this is an area where the government forcibly relocated Black South Africans under apartheid, leaving behind a terrible legacy of limited educational opportunities and limited economic opportunities that are slowly getting better, but still remain today. But for the purposes of the aging related outcomes we're looking at, it's really interesting in terms of the low SES exposures, especially with respect to the educational opportunities that these folks had in their school years. So the randomized cash transfer experiment we're drawing from is the HIV Prevention Trial Network Study 068, locally called Shwakoteka. This was a phase 3 randomized control trial PI'd by Audrey Pettifor. And I am so lucky to have Audrey as my faculty mentor while I was here at UNC, but like even more lucky to continue to be able to work with her and to benefit from her mentorship. Anyway, we leveraged the fact that this trial was nested within and sampled from this larger Agincourt study site. The trial was originally designed to assess whether cash transfers would be effective at preventing HIV infections in young women, a population in South Africa with extremely high HIV burden. Young women from just over 2,500 households were enrolled in the trial, randomized 1-to-1 to receive the cash transfer intervention or to a control condition that received no cash payment. And then in terms of what the cash transfer intervention actually looked like, Intervention households received monthly payments of 300 Rand, which was about $36 US at the time, for over like the up to 3-year study period. Monthly cash transfers, $36, up to 3 years. And importantly for us with this particular study, the cash transfer payment was divided up between the young woman who received 1/3 of the payment directly to her, and the rest of the payment divided up to a household member who was identified as the primary caregiver of that child. So the transfer could reach other household members in the household, both directly if they're the primary caregiver of the child, or indirectly through household spillover mechanisms of just injecting income into the household. All right. Oh, and I also wanted to mention here that there was a condition on this cash transfer. Young women had to attend school 80% of the days in the prior month to receive the payment. But surprisingly, so I think all of us, nearly all of the young women in the study met that condition in actually both the control and the intervention arm. So all of the payments were essentially universal to the intervention arm, and the effects that we see are not likely to be due to the education condition, since it was essentially met in both arms. So the Halsey cohort is what we use for a lot of our aging related outcomes. It is an observational cohort of older adults that was randomly sampled again, luckily for us, from this larger Agincourt sampling frame. They started in 2014, 2015 with a baseline wave, enrolling just over 5,000 men and women over the age of 40. I am now over the age of 40, and I take a little bit of offense that like I'm being eligible for this aging cohort. If anyone else is feeling similarly, I'm right there with you. But this is a really also a great data resource, an incredible cohort to work with. They collect really broad swaths of data in each of the waves, focusing on aging related health in general, but with particular strengths in cognitive function, but also HIV and cardiometabolic health. And we've returned to this cohort 2 more times so far over the course of 7 years. So we have 3 waves of data, and the larger study just got renewed. So we have another 2 rounds of data collection planned going through 2027. I think it's helpful for the purposes of setting up this analysis to show how the data sources are related in time. So the HPTN 068 transfer intervention ran in Agincourt households from 2011 to 2015. And then the Halsey cohort began essentially just after that, with a little bit of overlap starting in 2014, 2015, and then with 2 more waves of data collection through 2021. And like I've maybe been hinting, but not actually said, because these 2 cohorts share the same sampling frame, we were actually able to identify households that were enrolled in the cash transfer trial with members who ultimately went on to enroll in the Halsey study, which set us up really nicely to be able to do this very analysis. So we can use that randomized cash transfer exposure, but then assess the impacts on the household members who are older and not the original intended targets of the cash transfer. Specifically for this one that I'm showing you here, we're looking at memory decline in these older adult household members. Many of you who work in the aging space probably already know this, but accelerated memory decline is a hallmark of Alzheimer's disease and related dementias. And we measured this with episodic memory, and we measured episodic memory with an immediate and delayed word trial. Essentially, we read a list of words to the study participants, ask them to repeat it, and then we sort of distract them with a couple of other survey questions, wait some time, and then we ask them to how many of those words they can remember a few minutes later. So we have that at each of the 3 waves. We Z-standardized the memory scores, so they had a mean of 0 and a standard deviation of 1. If you're not used to seeing things in this way, the like effect sizes are going to look really small. I'm preparing you for that, but they're in standard deviation units. And so they were also comparable across the waves. And then we were able to look at whether the slopes of the memory scores over time were different by the cash transfer arm. And so it's not necessarily the memory function, but the like rate of decline that we're really interested in as being related to Alzheimer's disease and dementia risk. Okay. So the actual analysis analytic setup here is this was such a simple analysis to ultimately end up running because we had this nice randomized exposure. We could just run an intention to treat analysis. We used linear mixed models to account for the longitudinal data with repeated observations over time per person. We included weights for selective mortality and attrition. Because this is an aging cohort, there was not an insignificant amount of deaths between waves, but we attempted to account for that with weights. And the main thing we're interested in this model is the prediction of the memory slopes, like I mentioned in the previous slide, and whether they differed by cash transfer arm. And then we did some stratified analyses here as well. So we looked overall in the total overlapping study population, but we were also able to look by age group, gender, educational attainment, and baseline household assets to see whether the cash transfer effect, if there is one, whether it differed by these subgroups. Right. And then in terms of the study population, I wanted to show you first with some relief that the randomization up from the original cash transfer trial did seem to translate onto the older adult population fairly well when we extended it there. You'll see we had close to 900 total Halsey participants who were in the cash transfer households when it was administered. And we've got a nice split between the exposures. That is about 430 people in each arm. And the total population was pretty well balanced in terms of sociodemographic covariance between those two arms. So like age, gender, marital status, education all look fairly comparable. And importantly, because of the structure of the cash transfer payments, they're also pretty comparable with how the older adult member was related to the young woman in the trial, with over half of them being a mother or a father. So here are the results. This is what we found so far. With that, apologies for like just pasting model output here, but I'm going to walk you through it. We have an intercept here showing that on average, the memory function at baseline was about a 0.5 standard deviation in the control arm. The next effect estimate here for the cash transfer is showing that that there's essentially no difference in baseline cognitive function in the intervention and control arms. If anything, the cash transfer had a slightly smaller, cash transfer arm had a slightly smaller memory score at baseline than the control arm. And then our time effect estimate here is showing, like, as you would expect with an aging cohort, memory scores are declining over time with a 0.03 standard deviation unit decrease with that slope. And then the effect that we're most interested here in is this interaction between the cash transfer intervention arm and time. So this is showing whether the slope of memory decline is different for the cash transfer arm versus the intervention arm. We found that it was significantly different with a magnitude of 0.03 standard deviation units, slower memory decline in the cash transfer arm relative to the intervention arm. I hope I prepared you enough to like be kind of impressed, even though it's a really small effect size, but I'm gonna walk you through why we actually think this is or anchor it a little bit to communicate the size of this effect. So here's a graphical representation of the model output with the cash transfer arm in blue and the control arm in orange. And we see that slight difference in memory score over there at wave 1 at baseline, with the cash transfer arm starting a little bit lower. But then you see over time this 0.03 standard deviation unit slower memory decline for the cash transfer arm really accumulates over those 7 years of follow-up. So that by wave 3, we're ending up that the cash transfer arm is like ending at wave 3 after 7 years of follow-up with a higher memory score of about 0.17 standard deviation units. Again, that might be a meaningless number for you, but to anchor that a little bit, in this population, 10 years of aging gets you a memory decline of around 0.2 standard deviation units. So like this effect is pretty big. I mean, equivalent to offsetting about a decade of aging in just the 7 years of follow-up. So we're excited about this. I think it's a result that's like worth shouting about. Oh, and then without getting too bogged down in the details, I did want to show you what happened when you look at these slope estimates across different sociodemographic strata. Here we're looking at it for by gender, by age group, also by socioeconomic status and educational status. And the answer is essentially like, these are pretty stable estimates across all the subgroups that we looked at. There's no like statistical difference between any of these. So if the cash transfer is working to produce slower memory decline, it seems to be doing so for everybody relatively stably.
Can I ask you a question? Did
Yeah.
you look at whether the older person was a parent versus grandparent other?
Yes. And so with the idea that the parents are the ones that are most likely receiving the money directly. And we found, interestingly, that there was no statistical difference in terms of like who you were and how you were related to the we've done a little bit of speculation, coupled by that. But we are thinking that the people who are most likely the primary caregiver of caregivers of these young women are like their mothers, right? And those women in the whole example are relatively younger than women. Right. So like those are two like kind of structural differences. And those are the groups that we saw they have different patterns of memory decline than right. So like so we're just thinking that there's something structurally funny going on with, because those are the people who are most likely to be the direct recipients, but they're also the people who are less likely to into the cash transfer. But we haven't been able to like fully disentangle, but we did look at.
And I'll just say on that too, when we asked people how they spent the money, and I don't think this is different from other cash transfers, like female caregivers, they're not really spending the money
They didn't rush
themselves.
out.
They're like buying food for the household. They're buying, they spent a lot on education for kids in the home. So it's being spent on the household. And so, and then we've talked about also stress pathways of being a primary caregiver in a home, but
Thanks.
But the story that we were expecting was like the direct recipients would have had a
little
higher
more
effect,
of a
but we're thinking that like the gender and age effects are sort of hiding some of those. Okay. Great.
Can I ask another clarification?
Yeah, this is like a great one, because I was just gonna go on and like run through a bunch of other different things. So a few questions about
So
this.
my question is, when the 068 ended, did the control households get anything? They got nothing. Okay. Wow.
that was like 12 years ago.
Did you look at how the money is being spent, or who the healthcare investment in household?
Yeah, there are data on this, and there have been some studies from the perspective of the like young women trial about what the money was being spent on. And Audrey, I'm sure you can speak to this better, but I know that a lot of it was being spent on like educational expenses, which is sort of as the trial was intended, but also food and household expenses. Sort of like offsetting the general costs of day-to-day household activities. We are really interested in this question, particularly with things as they relate to like purchases that we think people might be making that can support their cognitive health. And so like future work is, we're planning to do some future work in that area. South Africa is a place with like a large social protection landscape with actual government cash transfer. So there's a lot of ways that people can accumulate cash transfer income and also like spend on different things. So we're interested in those questions for sure. But with this particular cash transfer, I think the main things were schooling expenses, but also like the young women were spending on like pocket money for things that they wanted to do, which is also an important thing to do with that income.
So you said, what was their income before the cash transfers or without the cash transfers?
So income measures in this area are sort of like difficult and unstable to measure, but this is a meaningful increase, actually anchored to what the government child support grant, which I'll talk about in just a minute, but like anchored to monthly payments of what a real cash transfer in the country is looking like. The extra 300 Rand a month as another anchoring thing would push people from below the food poverty threshold to above it. But it's hard to actually pin it on like what percentage of their income, because the income is kind of difficult to calculate in this setting.
If a lot of the money went to the kids' education, then what are the mechanisms that would lead the adults to have less memory decline? I mean, I can think of one, it's a bit of a stretch, but you know, if the kid becomes more educated and the kid stays in the household, maybe there's more stimulating conversation. But maybe that's a stretch. I'm not sure. I certainly understand that if, you know, families more well fed, that is good for brain development, but just wanted to hear, I mean, I don't know, like, what the percentage is. If it was like 90% went to education, then I'd be really worried. If it's like, well, the mode was, you know, 30% and that was education, and there's lots of other things that.
Yeah, and that's a great question. I actually don't think it's through this education pathway, but I do like it. Like the education of the younger adults in the household could plausibly lead to better brain function in older adults. So even spending on education can free up other household income to make all sorts of different purchases that wouldn't otherwise be available if they were spending it on
They're starting themselves
previously
to send
spending
their
it
kids
on.
to school, then. they're
Yeah.
not-
And so we've done some other work in this area, just looking at what kinds of things people have in their house over time and how that relates to cognitive function. This is observational using different data sets, but we're finding like strong effects of things that you might not initially think of as being related to cognitive health, but things like having a cell phone in the house is like strongly linked to positive aging related health outcomes. We're thinking through the cognitive stimulation that comes from being able to maintain social connections, right? Like, or just being connected to your larger social network. Transportation funds are also important. We're thinking similarly, being connected to your network, being able to interact with a larger network is important for maintaining brain health. But like these relatively small purchases, like having a little bit of extra income to make those could plausibly lead to these kinds of cognitive brain health in ways that maybe aren't like entirely obvious.
So I know nothing about the cognitive decline literature, but it's making me think about, so there's a literature on poverty, stress, and cognitive bandwidth, right? And so I'm curious, like if you have like measures of of stress that would allow you to kind of look at that.
That, thank you for saying that. That's actually an area that we're really interested in pursuing, and we have good data on with the Halsey cohort. So we have the ability to like create an allostatic load measure based on stress biomarkers. We also, I mean, this is a really interesting cohort in terms of life stressors across the life course that they've experienced, and we've got good modules of just like self-reports of the kinds of stresses these older adults now accumulated in childhood and early and midlife. So it's definitely an area of like, maybe that money didn't keep them from accumulating those life stressors, but maybe it does something to the biological stress processes now, like alleviate some of that we could actually be able to test.
Yeah, and just having, not being stressed out about your child's schooling.
Yeah.
Opens up more cognitive functions.
That's right.
And allow you to spend money better.
Right, without you having to actually purchase something that helps your brain, just like have lower stress, and have like a buffer around, an economic buffer around some of those things.
Yeah, okay. I was really curious, why you just gave 300 rand to the children and 200 to the parents or guardians. I know you mentioned that the total value of that was meant to mirror the child cash transfers that already exist in the country, but it's interesting to me that you would give more to the children and less to the parents when, I mean, I can hypothesize that the parents are the ones that are buying the food for the household and making investments in just like the household infrastructure.
Yeah, and I mean, Audrey could probably speak to this, the decision making around that, but I will say that the child support grant, the actual like South African transfer goes directly to the parent. With no payment to the child. But I think the like decision making around this was that it was really intended to support young women in staying in school. And because of some of the things you mentioned, like you really need the buy-in of both parties to make that pathway happen. So the young women need to feel the incentive to stay in school, but also like their adult caretaker needs to have some supportive mechanisms to keep the child in school. And so splitting it in that way was sort of like affecting both of those pathways. I don't know if you want to.
Yeah, but so only 100 went to the girl and 200 went to the parent. So it was a third to the child and 2/3 to the parent guardian. So 300 was the total payment. And when we started this, people were not like UNICEF and others were very anti giving money to adolescents. And I mean, it'd be interesting if you were here. I think there still was we had a ton of concern from NIH about giving money to minors. We had to measure social harms really closely. People were really worried about gender-based violence and violence within the home as a result of giving minors cash that was theirs. So it was sort of experimental, like the Zomba trial that the bank did was happening at the same time. And that was the only other trial at that point or study at that point that was giving money internationally to minors. To this day, I don't think there are any like government programs that give money to adolescents as part of a government program. So it was kind of experimental, and I'm not sure like the policy has moved to a place where people are actually thinking of giving government transfers to minors. So yeah.
Do you know how often the parents just?
So from the self-report from the questionnaire, it was actually really surprising that the vast majority of girls said that they got the money directly, they had full control over it, and they spent it how they wanted to spend it. So it was I can't remember the exact percentage, but it was very small. And definitely there was no control, like we were also worried about partners, but that was not an issue. I think just because I guess they lived at home and, you know, the male partners offer didn't even know that they were getting this money, I guess. So, but yeah, most girls, like some of them told us, you know, they would go get the money from the post office. So we set up an account for them at the local post office, and they would like spend it before they get home. Just go get it and spend it. That's a good way to, yeah, so. And we had no serious reports of social harms as a result of the cash. So it was good. Lots of positive qualitative outcomes too from just giving adolescents cash and having cash to spend as they chose to spend it. It was the first time most of them had any their own like resources to spend, on their own, for their own needs.
All right, so promising results from that randomized cash transfer trial and memory decline in the older adults. Next, I wanted to cycle through a couple other analyses we have under this project to give you a better idea of the scope of our work and how consistent the findings are. All right. So first I wanted to show you the results when we extend that randomized cash transfer experiment to the larger Agincourt full study population to look at mortality outcomes. Here we have an expanded population of just over 3,500 older adult household members. They don't have to be in the Halsey trial. This is just the like following on the vital statistics database that the surveillance site manages and maintains. But we were still able to make this linkage back to the control and intervention households in the transfer trial and have complete mortality follow-up on those household members. And these results were published earlier this year in Social Science and Medicine, and find, I think, some interesting trends. Overall, we didn't observe statistically significant associations in the like full study population. And we didn't see any by sex, age, or marital status. But when we started looking at those socioeconomic variables, really pretty strong protective effects emerged in probably like the opposite direction that you're thinking, but specifically people in the higher household asset categories and in the highest educational attainment categories seem to respond to the cash transfer with better survival in ways that we didn't see in the lower parts of the distribution, socioeconomic distribution. Specifically, participants in above median household asset categories at baseline, the cash transfer arm had a 30% lower hazard of mortality relative to controls. And among those with at least a high school education, which is like fairly rare in this setting, the cash transfer arm had more than a 60% lower hazard of mortality to controls. So exciting findings in this mortality space, maybe a little bit counterintuitive. We are thinking that this has something to do with the really like skewed SES distribution that we're working with in this setting. So the people in the higher asset categories are still like relatively economically deprived. Similarly with the education space, we are thinking that the cash transfer can really only work in households or in people with like a little bit of extra that they're working with, right? So the cash transfer to the lower household asset members is likely going to immediately put out some fires, right? that they need, like some economic immediate things that they need to deal with, and they're not going to the purchase of extra cognitive stimulation, things like cell phones or transportation and things like that. At least that's our speculation here. But exciting to see, at least in some subgroups, that the findings are translating into protected mortality effects as well. All right, and then we've been talking a little bit about these, but I won't go into too much detail, but I wanted to highlight we're also looking at ways to find natural experiments in these real world actual social protection programs in South Africa run by the South African government. Two of the largest government cash transfer programs have had recent expansions in eligibility that we've been able to leverage to look at the impact of those expansions on aging related outcomes in this population. Specifically the old age pension, which is a retirement fund, which is designed to provide livable income to South Africans of retirement age, recently expanded their age eligibility for men from what it used to be 65 and now it's 60. And the child support grant, which is another, which we've talked about a little bit, designed to offset the cost of raising young children, expanded the age limit of the children that it covered from age 7, when they first rolled it out in 1998, all the way up to age 18, where it is now, and sort of a stair-stepped age expansion there. So we leverage these expansions and eligibility as ways to see whether, to isolate what we're trying to isolate a causal effect here of these age expansions on aging related outcomes. And these are all talks in and of themselves, but just to give you a flavor of what we're doing, here are some of the findings we found so far. This is work on the old age pension, which is led by Janet Jock, a doctoral student at Indiana University, and published recently in the Journal of Aging and Social Policy. Here we found that those men in the transition cohorts of those who were exposed to increasing amounts of pension during that age expansion from 65 down to 60, actually did have higher cognitive function than we would expect them to have in the absence of that extra income. And you can see it almost follows like a dose response relationship here. And we did not end up observing this trend in a same aged cohort of women who had not experienced that same age expansion. So women have always been eligible for the old age pension at age 60. So this negative control analysis that we did gave us a little bit more confidence that our results were actually due to the old age pension expansion. Great. And then for the child support grant in this last flash, this time with similar results, this is looking specifically at the child support grant effect in women. So most of the recipients of the child support grant are biological mothers of children. And this work is led by another doctoral student at IU, Rishika Chakraborty. And we here divided women into women in the Halsey population into groups who had received higher than median child support grant income versus lower than median child support grant income across their lifetimes by basically mapping all of their kids' birth dates onto these age expansions and seeing what they were actually eligible for. And we found that overall women with higher accumulated child support grant income had higher cognitive function scores when they enrolled in Halsey relative to those with lower child support grant income, with a magnitude of, I think this was 0.15 standard deviation units, so like a fairly large effect. This finding held for women with 1 to 4 children, but decreased a little bit and bordered into not statistically significant results in women with more than 5 children. This is another thing that we're sort of speculating on, would love to understand a little bit more, but we're basically attributing it to the cognitive costs of having a really large family and raising lots of kids. That may be the child support grant income, even though it's stacks for each child, just isn't enough to overcome having a household of 10 kids that you're taking care of. Okay, so let's take those results from all 4 of those analyses, and I'll try to triangulate them a bit for you in the last couple of minutes. Pretty unique strengths of these analyses are the randomized and pseudo-randomized cash transfer exposures that we were able to create, and that perform nicely in these older adult populations or with this linkage to the Halsey cohort. And then the long-term longitudinal follow-up we were able to leverage from the overlapping data sources. And to high-level summarize these findings, all of our results generally support the idea that cash transfers could be useful to promote healthy aging in sub-Saharan Africa and rural South Africa in particular. And these results were consistent across these 3 different cash transfer schemes and across different cognitive and mortality-related outcomes. Specifically, we found that for the randomized cash transfer, there was no effect on baseline cognitive function. But we observed protective effects on memory decline and mortality outcomes, but the mortality outcomes were limited to those already in higher wealth and education strata. And for both the old age pension in men and the child support grant in women, we found protective effects on baseline cognitive function. We're also finding preliminary positive protective effects on longitudinal memory decline with both of these setups as well, though we haven't finalize those analyses. And we're still working on the mortality outcome analyses for those, but for the child support grant, it's looking like those results will be null. So those are the mortality findings with the child support grant in women in particular are not looking like we're seeing effects there. But by and large, taken together, our findings really seem to support the idea that cash transfers can be useful to promote population level healthy cognitive aging and brain health, but with maybe slightly more qualified findings where it might be a little bit stronger for men than for women. And lots of interesting sub-analyses and follow-up questions around that one. All right, and then for the future, we're first, wanting to complete that matrix of pre-planned analyses with all of our cognitive and mortality outcomes. We also have some interesting additional cognitive outcomes that we're looking at. We have a dementia probability score that's based on clinical diagnoses within a subcohort of HALSI. And as a spoiler, we're also finding strong effects of the cash transfer on that outcome as well. On a longer time horizon, we're really interested in getting more granular into the nuts and bolts of these cash transfer exposures and thinking about how they might be related to aging-related outcomes. The next step is really like thinking about how the South African population in particular is accumulating these cash transfer exposures across their life course. And we're really interested in mapping that, adding it all up, seeing what life course time periods might be most important to target people with cash transfers in order to promote their healthy aging trajectories, seeing whether men versus women are better targets for the cash transfer income, and like understanding how the household pooling of all of this income comes together to promote the health of everybody in the household, and whether that's similar for everyone or different in different subgroups. So we've got a lot of plans for the future. We're wanting to build on this awesome platform that the Agincourt surveillance system has set up, adding these cash transfer exposures into it and being able to look at a bunch of different health outcomes with it. All right. So thank you guys. Before I end, I want to send a huge thank you to our funders at NIA, our study team members at IU, University of Michigan, University of the Witwatersrand, Harvard University, and here at UNC. I'd especially like to call out my co-lead on this project, Lindsay Kobayashi at University of Michigan. She is amazing to work with. But of course, also to Audrey, thank you for continuing to work with me and for all the mentorship along the way. And then just a final thank you to the students, especially the student team at IU and the Agincourt field team and Agincourt leadership team. This is a picture of all of us last year in August. They're incredible to work with and bring so much to the findings and interpretation. So thank you.
More minutes for questions.
I have two. One is for your mortality results. I was wondering if the education and the higher assets potentially was a reflection of them potentially using health services more, potentially when somebody got sick or that kind of thing. Not just having those resources previously, but just preventing the death potentially by using health services. But then my other one before I forget it, which was you made a comment about the child support one. Do you know that the people got the child support or they were eligible for it? I think you made it sound like they were eligible, but you didn't necessarily have data on whether they got it.
So all of our main analyses here are basically trying to create intention to treat analyses. So it's eligibility. Yeah. So we're like adding up what you're eligible for under these like exogenous policy expansions, but not whether you actually received it or not. We do have some spotty data on receipt and are interested in like making that ultimate triangulation. But for policy inference, we're kind of okay with just using the eligibility exposure as the one because it maintains the exogenous nature of the exposure, but then also like that's what the governments are going to actually enact, right? Like the policy, but they're not going to actually force people to uptake it. Your first comment though,
education and and having more assets, being more likely to use health services when somebody gets sick as opposed to just sort of a resource.
I see. Yeah, so that they're able to, and then like that's the pathway
Prevents
to
the
the like
mortality,
longer term
potentially.
mortality, the mortality effects. Yeah, that's something, and that's something we could actually look. We have great healthcare utilization data, both from the Agincourt site and in the Halsey cohort. And also just spending, like consumption patterns on healthcare in particular. It's a great idea.
Have you done parallel analysis of some of the physical health indicators like blood pressure, hypertension? You know, that might contribute also to cognitive decline. They
Yes.
respond in the same way to questions.
So we have done, one of the graduate students at University of Michigan has led a paper on blood pressure and the old age pension expansion, and actually found opposite results. So higher blood pressure in men in these transition cohorts in this period, you know, right after receiving the old age pension. So we're still parsing those. I mean, it's a paper that's under review, but it's not consistent on all of the health outcomes that we've looked at. There's still, but we haven't done any of the physical functioning pieces, though there are data on that. It's really interesting to look at.
It seems like this really interesting opportunity to delve into these channels to some degree, and especially with cognition, you know, I think there's some work on South Africa that shows that once you give people pensions, their household sizes grow because people move in with them because they have more money, which kind of dilutes the wealth or the anti-poverty, but it could increase the companionship side, which for cognition could really matter. So anyway, just a thought.
Yes, and
As
we
you
have
get into that granularity.
We have thought about this, and especially with the surveillance system data,
Yeah,
like
'cause you know
we
composition.
have household composition longitudinal over time.
So that's
So
really interesting.
both, yeah, thinking of the cash transfer could actually induce changes
Yeah.
in the household structure in ways that could promote or like harm long-term.
Yes,
cognitive
no,
health.
right, yeah.
And
You
it's
could mess
something.
up the health of some and improve the health of
Right.
others.
Yes, exactly. But like it's an important part of the story and one that we can look at. I mean, it's going to be a huge data undertaking, but one that we're really interested in doing.
Yeah, I'm just, so, you know, I'm curious if you have any insights on so, you know, one way you could think about like comparing cash transfer to like more traditional intervention, right? That's for example, something that's targeting dementia specifically, it's kind of as a benchmark, right? And just from a policy perspective, that's kind of what you could be interested in, right? So should we do a cash transfer that leads all, you know, impact all of these outcomes, right? Or should we have a more targeted program,
Yeah.
right? And so I don't know what the question is. I think it would be interesting to like have, you know, some comparisons. I don't know if you're planning direct trials or anything like that.
That's nothing on the horizon now, but I agree with you that that would be interesting. And I mean, I'm struggling to think of what would, especially in like a rural South African space, like what would even be a comparison intervention that we.
But I'm wondering, Molly, so for the girls cohort, we did some modeling of cash plus, which is a big thing in adolescent space. And I don't know what the intervention for younger women, it was like cash plus like a caregiver, parenting intervention, or cash plus a mental health intervention. So, you know, that Marie Stoner led with using sort of some causal inference modeling techniques. And I feel like you could do something similar here if you took the cash and thought about like, I mean,
But
it's not
some
quite
sort
the
of,
same as
like,
comparing it to.
Dementia care or dementia prevention.
Yeah,
intervention.
yeah.
I mean, maybe we could even just model what something of like that might look like, even if we don't have a great example in the South African space so far. But I mean, part of the benefit of looking at a cash transfer intervention is that like it's not targeted for this specific outcome, right? And there's other benefits to it as well. So putting it head to head with like a
Right, but
dementia
I was
intervention
like documenting that, I think
is helpful.
Right.
Yeah, agreed.
All right, well, we're out of time, so thank you very much. Look forward to seeing more of these results come out.
Thank you for you.
Almost.